Picture this scenario. You finally got to your embryo transfer, you did it. And now you are in that excruciating 8 to 10 day wait, wondering, did it work or did it not work? I'm Dr. Lucky Seegon, a double board certified OBGYN and REI, here to fill you in on all of the possibilities. I'm a very positive, optimistic person, so let's start with the best scenario, the most likely scenario in a lot of cases, which is it worked. So you check your HCG level on the blood work, and this can be done anywhere from 8 to 10 days after the transfer, and your clinic will call you with the results and give you a number, and they'll help you interpret what that number means. And hopefully it's above a certain threshold where you start to feel more confident that this transfer worked and is going to be successful. But the monitoring doesn't end there. We, generally speaking, will bring you back 2 to 3 days later and we'll retest the blood levels to make sure not only was that first level appropriate, but that it is rising normally, and that is a sign that the pregnancy is progressing. So let's say it rises normally, it doubles over 48 hours. That's a great sign, and usually we'll wait about a week and we'll schedule you for your first pregnancy ultrasound, because it takes about a week for those levels to continue to rise above a threshold where we can actually expect to see an early implantation in the uterus on ultrasound. Now, what if it's not rising normally? It's plateaued, or it's rising but very slowly. Well, generally speaking, we'll typically bring you in for another blood test and kind of track things closely, because that's a sign that the pregnancy may not be progressing as we had hoped, and it could also be a warning sign of something called an ectopic pregnancy. Either way, we're generally bringing you in for that first ultrasound about a week after the blood tests are done, and if everything's looking good and progressing, we're typically also checking your blood levels and making sure you're on the right dose of progesterone to continue supporting the pregnancy. And in my practice, I'll bring patients back on a weekly basis for about three more additional visits. And if all looks good, we start to taper off those medications, the hormones, the estrogen and progesterone, and discharge patients back to their OB at around 9 weeks. All right, now let's review the scenario that we hope is not the case, but if the pregnancy test is negative, your HCG level is negative 8 to 10 days after the transfer. This means the transfer did not work. And we will have you stop taking the estrogen and the progesterone that you've been continuing to take post-transfer in the hopes of supporting an early pregnancy. And once you stop taking those medications, we can anticipate that it will cause a withdrawal bleed. The lining of your uterus, which we had built up in preparation for transfer, will now break down, and it will be like getting a period. At this point, it may make sense to go straight into another transfer prep process and come in for a baseline scan, blood work, and start taking estrogen again to build up the lining. But I think that this is an opportunity where everyone should have a conversation with their physician, and they should talk about why the transfer didn't work. Most often, we're not going to be able to give you a definitive answer, but we should review the grading of the embryo, the way the lining looked, how the transfer itself went. Was it easy and straightforward, or were there any unanticipated obstacles? But more importantly, is this a point in time where we should take a pause and reconsider whether we need to do another retrieval? What embryos do you have left? What are their grades? Is this enough to meet your ideal family building goal? And in terms of testing, are there things that we could be looking into that we didn't look at prior? Ideally, you go into the first transfer having tested for all the things, but let's say you did a saline sonogram. Maybe it makes sense to, just for good measure, do an HSG, because that's going to give you a different view of the uterine cavity and additionally information about the fallopian tubes if that's never been looked at. It may make sense to do a hysteroscopy for diagnostic purposes, and maybe we collect a biopsy of the lining of the uterus to rule out things like infection or inflammation. So there's a laundry list of things that we will go through with a patient depending on the scenario, and it may mean taking a pause, going on birth control pill to freeze you at day 3 of your cycle, or taking the month off and just using that month to get additional information, to do additional testing, or maybe even to do another retrieval. I know the waiting game can be really hard, especially when you don't know which route things are going to take. My advice to any patient is always talk to your doctor before the transfer of who's going to call you with the results, and if it's not them, how soon can you speak with them? I think the key is really knowing what to anticipate, and that even comes down to what to anticipate when it comes to communication. I think it's always helpful for patients to have a short interval follow-up to talk about what happened with the transfer, where you stand, and potential next steps. And some patients may not be ready for that conversation. And if that's the case, I think it's fine to also take a pause. But in general, you just don't want to find yourself in a situation where you're feeling in the dark and you're waiting to hear from someone and you're waiting for answers, because I think that needlessly adds a layer of distress to the situation. So have a conversation, have a plan, and if part of that plan involves taking a break for your mental and physical health, I think that that's a fantastic idea in a lot of scenarios. But I think the key is really clear communication with your clinic and your doctor and understanding everything there is to know about what happened and how to move forward.